I will start with the declaration of conflict of interest. There was no conflict of interest with regard to any involvement in product development or marketing. However, there is an intellectual conflict of interest insofar as I have published a book on the subject, which is currently being printed in German and will soon be translated into English. Of course, this is also an advertising block for my book. Yeah. So I will give you a brief overview of the structure of my presentation. First, I will make a few general comments on the developmental tasks of puberty, and then, secondly, on the special challenges of female adolescents. These extend, thirdly, to the development of the ability to experience sexuality and the shaping of sexual relationships. Following on from this, I will, fourthly, discuss the analogies and parallels between gender dysphoria and anorexia nervosa, and finally, derive some conclusions for therapy from this. Well, the idea that adolescence is the best time of one's life can only have arisen from the hazy, rose-tinted memories of adults. Never again will the individual, especially the female, feel so alienated in her own body, and never again in one's life will a person have to deal with such wealth of radical changes as during puberty. The aim and tasks of puberty and adolescence are consolidation of a new body identity and ego integration of the changing body, becoming aware of the individual sexual preference structure, shaping sexual relationships, and develop one's own sexual identity, including a potential homosexual coming out. Autonomy from parents and determination of own attitudes and values, and developing realistic life and career plans. This requires resilience, assertiveness, and great willingness to change, but also, on the other hand, flexibility and advanced emotional and self-regulation skills. However, the situation varies depending on the biological sex. For girls, the necessary steps of the first three developmental tasks are particularly challenging. More on this later. Let's have a brief look on the brain maturation process. I can be very brief on it, thanks to the talk of Sally in the morning. Until a few years ago, it was commonly held that the typical behaviors of adolescents during puberty and adolescence were primarily due to the effects of specific sex hormones. There is now consensus that hormones and directed remodeling and reorganization processes of the brain interact in a unique way during this time. The maturation of the brain proceeds from back to front, so to speak, from simpler to higher function. It is not all brain regions matured at the same time, like Sally told us in the morning. Finally, the prefrontal cortex, which is responsible for planning, considerate decision, level-headedness, and impulse control, matures. Many of the confusions of puberty can be explained by the sequence of brain maturation. These are emotional fluctuations and difficulties in regulating emotions, alternating feelings of superiority and inferiority, identity and role insecurity, shyness, the so-called shame crisis, lack of sense of danger, risky and reckless behavior, limited ability to plan and act with foresight, egocentrism, and rebellious behavior. These behaviors and temporary impairments are typical of puberty in both sexes, but there are some special problems in female adolescents. These are, in first position, depressive self-concept and insecurities in body perception, which are characteristic for many, not for all, but for many female adolescents. It's noteworthy that this applies equally to the non-clinical sample of schoolgirls and to mentally ill adolescent girls in need of treatment, albeit with different frequencies and severity. Adipose tissue increases by 50% in girls during puberty the female body becomes curvy. Menarche can be expected around 2 years after the onset of breast development. All these maturation-related changes to the body require girls to make considerable efforts to adapt. In view of these enormous upheavals, one question that arises is, how do young girls' female body image and body satisfaction develop? The term body image refers not only to the perception and ideas about one's own body, but also to its subjective evaluation. The latter is largely subject to social norms, cultural influences, and contemporary aesthetic ideals conveyed by the media. There is considerable pressure, especially as a result of media hypersexualization. The unrealistic ideal of androgynous slimness and virtual beauty prevents girls from appreciating their growing bodies and the symbolic meaning of these changes in terms of fertility. Many girls grow up with Barbie dolls whose artificial figure with an extremely slim waist and equally slim hips leaves no room for organs, let alone pregnancy. In comparison, girls generally perceive their feminized bodies as too soft, out of proportion and fat. And as you all know, there seems to be a difference between men and women with regard to their self-perception. There are some reliable data for that. The KICS, it's a German study, the KICS study by the Robert Koch Institute found that about 18% of nearly 1,000 girls between the age of 11 and 70 years were overweight or obese. 7.5% were underweight, and nearly 75% were of normal weight. However, the data also revealed that many girls objectively of normal weight suffer from distorted body image. More than 50% of the 11 to 17-year-old normal weight girls stated that they thought that they were a little too fat or much too fat. Multiple studies provide evidence that a large number of adolescent girls develop massive self-doubt. They consider themselves ugly, unattractive, and feel ashamed of certain parts of their body. One other special point. The current aesthetic ideal of the vulva is defined by taut labia majora that covers the labia minora. Because they don't know that the pictures in magazines have often been retouched, many girls are unsettled. The strong presence of nudity in the media and erotic or pornographic images on the internet have certainly contributed to the development of aesthetic norms for this part of the body. Oral sex is a part of the sexual repertoire not only for young people. The intimate shaving fad is a logical consequence, which in turn leads to new visibility of the external genitalia. In the words of Borkenhagen and Brehler, one part of the body that was previously primarily part of the primate sphere, the pubic region, is now subjected to a design imperative. The menstruation. The first menstruation is generally an ambulant event for girls. On the one hand, it is urgently awaited by most girls, as it symbolizes growing up. But on the other hand, the period confronts girls with a wealth of discomfort. Girls feel disabled by the loss of their childlike independent body feelings, the loss of cleanness and control. In addition, many girls suffer from dysmenorrhea in the first fertile years, changes in skin appearance, cravings, premenstrual mood deteriorations. Quite a few girls feel that their period is a burden and an imposition. So let's have a look on the topic shaping sexual relationship. We distinguish the following functional dimensions or significant aspects of human sexuality: the dimension of sexual pleasure and the function of reproduction, as well as the relationship and the identity aspect. Sexuality is a basic need of every human being for sensual pleasure, closeness, intimacy, security, self-assurance, and confirmation of being lovable and desirable. Puberty and adolescence are the life history phases in which sexuality become central themes, and during which girls ideally develop a positive relationship with their bodies. With its four aspects of meaning, sexuality accompanies us through our lives with quite different individual sex and life stage specific importance. There are significant differences in the somato and psychosexual development of boys and girls. For boys, the onset of puberty is directly linked to the pleasure dimension of sexuality. Only 4% of boys report unpleasant associations with ejaculate. You pronounce it like that? Okay, you can read it. Ejaculate. Okay. Which should not wonder, because it's directly linked to the orgasm, a very pleasant sensual feeling. In contrast, a third of the girls clearly indicate unpleasant associations with menarche, a further 22% ambivalent ones. So if you put that together, more than the half of the girls, they have some problems with it. Unlike boys, girls reach their reproductive capacity only after development secondary sex characteristics. The female body is now attractive and often commented on at an early age. Girls experience an external sexualization of their bodies. Sexuality is discovered in a girl before it unfolds within her. Female sexuality is initially shifted away from the pleasure towards the reproductive aspect of sexuality. Girls therefore need more time to discover and allow sexual sensations. Girls in puberty, nevertheless, are also curious about what love and sexuality has to offer. However, they are initially preoccupied with the relationship aspect of sexuality. It is the longing for a symbiotic love full of closeness and tenderness. The relationship with the girlfriend of the same age, with whom she shares fantasies, secrets, and tenderness, is very important for the process of detachment from the mother or parents. Quite a few girls go through a homoerotic transitional stage in early adolescence, including erotic sexual activities. In a series of successive and interwoven development steps, heterosexual girls later change to the courtship of a young man, which is characterized by libidinous impulses. The self-esteem boosting experience of feeling desirable seduces some girls to accept their first sexual intercourse as a form of psychological adaptation to their longing for love and tenderness and to mean something to someone. More than a few girls are irritated when boys tend to express their feelings and their need for closeness in a way that is strongly influenced by the desire aspect, the pleasure dimension of sexuality. Early relationships all too often fall because of these incongruities, discrepant expectations and needs. Nadrowski recently pointed out the potentially underestimated importance of early exposure to pornography, which some girls experience as disturbing and in some cases even traumatizing. Violent pornography, deviant pornography, and pornography with criminal content are likely to be of particular relevance here. Nadrowski argues that the increase in gender dysphoria among female adolescents since the 2000s correlates with the uncontrolled distribution and free availability of pornographic content in the internet. The appropriation of misogynistic sexual scripts based on false assumptions about sexuality and gender roles can reinforce a rejection of femininity and exacerbate the fear of becoming a woman. So, a short interim conclusion. Not for all girls, but for many, the physical changes that occur during puberty initially leads to a phase of deep insecurity. The development of a stable female identity for girls in adolescence is highly complex, demanding, susceptible to disruption, and accompanied by crisis. Young women are confronted with a wide range of demands and chances of all kinds, which open up unexpected freedom for some of them, but increased social expectations and omnipresence of power women as role models in the media put other girls under pressure to perform and to put them at risk of failing due to the enormous challenges and excessive demands they place on themselves. For some girls, the life model set for them by their chronically stressed and exhausted mothers, torn between professional and care work, is no longer an attractive model for their own female emancipation, which also requires necessary steps towards sexual self-empowerment. The real problem is not the desire to be a man or a boy, but rather the social pressure to conform. The media spotlights a way of dealing with sexuality that shows little respect for girls' age and gender-specific instinctual demands. This is especially true for internet pornography. Quite a few girls feel massively overwhelmed by the challenge of impending womanhood, and it is no surprising that they try to avoid in some way. The strong need for avoidance makes them receptive to alternative identification templates. Their fear of individual emancipation, which includes a critical reflection of unrealistic ideals of beauty and thinness, as well as internalized gender stereotypes, they try to compensate for by identifying with identitary collective and group affiliation. So I come to the parallels between anorexia and gender dysphoria. As you all know, eating disorders in young women are relatively common. Girls between the ages of 13 and 16 are significantly more likely than boys to exhibit restrained eating behavior, while at the same time being very dissatisfied with their figure and experiencing body alienation more intensively. The number of cases of anorexia nervosa treated as inpatients, at least in Germany, has risen over the past 10 years and increased during the pandemic situation, with the main burden being borne by pediatric clinics. The development and maintenance of anorexia, as you all know, is seen as a multifactorial disease process in which individual psychological factors interact with biological, partly genetic, familiar and social-cultural factors in the sense of a classic gene-environment interaction. The exact details, however, are still unclear, especially with regard to the interplay by various factors and their weighting in individual cases. There are various psychodynamic models that refer to the individual, especially early childhood life history, either describing intrapsychic conflicts or assuming a structural disorder, or considering unresolved developmental tasks to be in the foreground. Eating can serve as a substitute satisfaction for unfilled needs, as we all know. On the other hand, abstaining from eating conveys a feel of control, independence, and strength. Anorectic girls are hungry, not only in a concrete but also in a figurative sense. They are hungry for autonomy, but they fail on the cliffs of growing up, which means accepting the female body with its expressions and attributions and shaping the initiation of sexual relationship under the given social norms. Ambitious, perfectionist girls experience recognition within their peer group with their body strategy and are rewarded with feelings of stability, supposed independence, and the aura of extraordinary. Moreover, anorexia is a desperate attempt to stop the time, to put the body which is perceived as out of bounds in puberty in its place, to create order at least on one's own body when various other problems seem to lead to a dead end. Anorexia is often an expression of a search for the lost paradise of childhood, but it is also always a search for boundaries, for identity, for oneself. The body becomes the venue for inner conflicts. The great disciplinary achievement of starvation replaces control over one's own life. Much of what has been said applies equally to the genesis and typical psychodynamics of clinically relevant gender dysphoria. It is therefore not surprising that patients with gender dysphoria often also have comorbid eating disorder symptoms, with deviation in both directions, i.e. partial or complete anorectic or bulimic syndromes, as well as manifest obesity. I talked to Alison Clayton in the morning, and she told me, she mentioned that the proportion in the clinic in Melbourne of persons with comorbid eating disorders is about 25%. It is obvious that the body image disorder underlying the eating disorder is often closely linked to gender and sexual identity issues. So this slide shows you potential causes and contributing factors and its analogies and parallels to eating disorders, which of course is in first position the discomfort with the developing body, but also the self-hatred. What anorexia nervosa and gender dysphoria have in common is a massive rejection of their own female body. Similar to anorexia nervosa, trans identification offers adolescent girls another, albeit particularly drastic, opportunity to escape the changes and developmental tasks associated with growing up, and to express their individual suffering in a socially accepted form. In the absence of more mature constructive coping strategies, interpsychic conflicts are projected onto the body. Due to the lack of self-acceptance or massive self-hatred in conjunction with a pronounced body image disorder, aggression is turned against the self, let's say inwards, but also outwards against significant others. In both anorexia nervosa and gender dysphoria, relatives, especially parents, are exposed to strong feeling of helplessness in addition to the massive feelings of guilt and personal failure that very often arise. In both disorders, this sometimes exacerbates the symptoms of the index patients with a correspondingly pathological relationship dynamic. Anorexia and bulimia nervosa are often referred as modern ethnic disorders. This is undoubtedly even more true of the current hype surrounding the phenomenon of trans and non-binary. The importance of cultural influence, in particular the reinforcement mechanisms of online communities and social networks, are well known for both maladaptive dysfunctional processing modes. The fatal effect of social contagion, which can also occur via media exchange processes, as Lisa Littman told us. It as merely virtual encounters with like-minded or similarly vulnerable peers has also been conclusively described. It should be noted that there is a very conspicuous, sometimes voyeuristic fascination in our society for self-harming behaviors, especially among young women who submit to trends. Examples for this would be the cult surrounding the 1960s anorexic model Twiggy, who became a style icon of her time and contributed significantly to the popularization of anorexia, as well as the widespread interest of a shocked public in the fate of the 13-year-old heroin addict Christiane F. and the collective pleasure and fear through confrontation with the topics of prostitution and drug-related death in the book The Children from Barnev Zoo, which was published 1978 with more than 3 million copies worldwide. Another point, medicine and psychology are susceptible to the phenomenon of mass hysteria triggered by the media. And the enthusiasm for this leads to a new diagnosis that find their way into classification systems. Once the symptom patterns are codified, they can be found by those who are unconsciously looking for a way to express their otherwise difficult to verbalize distress. There is a clear parallel here between the diagnosis of trance that have become so common among young people today and the so-called multiple personality disorder in the 1990s, or even the classic hysteria. The conditions mentioned above affect young women in particular, who have always proven to be especially susceptible to social contagion. But what determines which mode of conflict processing or which maladaptive behaviors are activated in the case of deficient self-development or Christ-like decompensation during puberty? This is likely to depend on a large number of variables and pathogenic developmental conditions. In view of the far-reaching consequences in both cases, this is like choosing between Scylla and Charybdis, whereby a real choice in the sense of a free will decision cannot be made here, of course. So what conclusions can be drawn for the therapy? The focus of psychotherapy should be on dealing with issues of gender and sexual identity, and treatment should be open in terms of its outcome. On the other hand, frequent comorbid mental disorders must be assessed and, if necessary, treated at the same time. In some cases, the supposed comorbidity turns out to be the actual overarching problem that also feeds the desire to transition. At est, trans identification is a proxy for other difficulties. The focus is on the exploration and reflection of the different individual causes for the transsexual desire, which is wrongly defamed by representatives of the trans-affirmative approach as conversion therapy. One specific question is whether the rejection of one's own gender role and body could primarily be a repressed homosexual development or an maladaptive reaction to a puberty-related age role conflict. Psychotherapy can act as a catalyst for psychological change, growth, and the development of autonomy, particularly by helping to gain a better understanding of previously unconscious problems areas. Of central importance is the question of which idiosyncratic meaning is attributed to the desired and the undesired gender on the patient side. In other words, which specific aspects or stereotypes of one's own gender are rejected or considered desirable in the other. This often leads to the realization of how much past or current negative attachment experiences and possibly missing female and male role models significantly determine the current perception, including that of one's own gender role and one's own body. In therapy, those affected can question these attributions or repressive norms, according to which certain behaviors, preferences, and feelings are associated exclusively with one of the two biological sexes. All of this leads to the question of whether medical transition really expands the degrees of freedom, or whether this path does not rather perpetuate precisely those gender stereotypes that are perceived as oppressive. Critical reflection on gender norms invites people to find creative, above all, individual solutions and previously unimagined ways of living sexual, not gender, but sexual diversity that are much safer than transformative medical interventions. For this very reason, gender explorative therapy is the exact opposite of a conversion treatment. It aims much more at self-empowerment and is intended to enable the patient to develop the necessary skills for joint decision-making by gaining clarity about the causes of his inner conflicts. Final remark. With regard to body dysmorphic disorder, we will hear something about it later. Kohls and Rösner have recently pointed out how different the treatment strategies for gender dysphoria is in comparison, and have critically questioned the ethical justification for medical interventions on a healthy body that are associated with severe side effects and complications and lifelong consequences. In the case of anorexia nervosa, which is similarly based on a disturbed body image and often also a rejection of sexuality, nobody would consider prescribing laxative, appetite suppressions or thyroid hormones to the patient in order to enable her to achieve the desired body modification, in this case, the further self-induced weight loss. It would be more than obvious to draw more intensively on the experience gained with severe body image disorder in the context of anorexia treatment and to use this mutatis mutandis in therapy of gender dysphoria. It as the rejection of the sexual body. So I close with the words of Carolee Schneemann, a famous artist, a performance artist. Go back to the body. That's the place where most inconsistencies in Western cultures arise. Thank you for your attention.